Hey guys, it's Haitham Wadi. In this next video, I'm going to be showing you how to do a single port robotic suture rectopexy. So in terms of setup, I'll have the patient position supine. I'll place a Foley catheter. My incision for this will be a fan and steel incision, 3 to 3.5 centimeters. You could use a small or large access port. For my exposure and retraction, I like to use a Claudier fenestrated bipolar and a monopolar scissors. You're going to need a needle driver to do the pexy part. I always like to use a Rosie, it helps with the visualization. Pneumo set to 12 to 15. Air seal is optional. And of course, if you have the extended range instruments, it's always beneficial for the transabdominal cases. So to be honest, you could go with camera above or camera below. For me, personally, I played around with both, and I like the camera below option for this part of the dissection. I like having my arms above. I could cobra the camera to get a really nice angle, kind of snake around the rectosigmoid junction, and just focus on this right side initially. A lot of my retraction is going to be upwards and laterally. Got my left hand, the Cartier, doing a lot of the cranial um, exposure and retraction for me, and I'm using my middle and right hand to do a lot of the dissection right now. So for my suture rectopexies, I work in a posterior to lateral fashion. I try to get into that nice avascular plane. Obviously, when you have chronic prolapse, sometimes you'll run into issue with scar tissue formation, so it could be a little bit stickier than normal, but eventually you get to a nice clean area. I just work posteriorly. I go all the way distal that I can, ideally all the way down to the pelvic floor, thin out my lateral attachments, and start working laterally after that. Especially for lower BMI patients, this SP robot is really good. I don't really run into any issues with exposure, simply because I could really use that camera to find the ideal angle for visualization. Have that third arm just to the left of the screen, again holding up the sigmoid colon. I'm just going to keep working down this plane. Again, I have my bipolar ready if I need it in case I run into any bleeding that can't be encountered and satisfied with the monopolar scissors. Like I said in a previous video, the nice thing about this is there's really no limit to the reach. I mean, if I need to get more distally or lower down and I'm running out of arm length, all I can do is simply burp in the platform deeper, and this will give me additional length with the arms. These are smaller instruments, so one of the things I was first worried about when working with the SP was whether or not the instruments would be strong enough for a retraction that's needed. And frankly, I haven't run into any issues, even with the higher BMI patients, with that. I think it's really important when you're first starting out to really get a flow of how you want to do your cases. And once you have that, make sure the OR staff is really involved. And try to have a consistent OR staff when you're doing this in the beginning because it's going to be very foreign to them. Make sure your bedside assist. Um, you really work hard with them, train with them, ideally if you can, because this is very difficult for them to maneuver in this very tight space for the bedside assisting. You really got to get the hang of it. Alternatively, if you don't want to be truly single access, single incision, you can always add an accessory port laterally to where you're working. It'll make it much easier for them to get in and do any kind of necessary retraction or suctioning for you. Especially if you're working in a male pelvis, it can be quite cumbersome and difficult to you be facilitating with your instruments and also having the bedside assist come in with an additional instrument. It might be very difficult in terms of collisions. But as you could see here, I haven't run into any issues with exposure. I haven't had any issues with um, length of my instruments or extent to reach. I mean, just kind of some of the added benefits of using the SP robot. So once I finish my posterior lateral dissection, I'll test it, I'll tug on it to make sure I fully reduced any redundancies, and then I'll clear up the area where I'm going to be placing my sutures for the actual pexy rather than kind of blindly throwing them. I like to really clear up as much of the tissue as possible until I see that nice bone. So I like to use Ethibond sutures for the pexy. So you'll see me suturing them into place here right now. And I just throw, 2 or 3 sutures at most when doing the pexy. So I'll get a good bite of that periosteum, make sure I have a good anchor, make sure it feels nice and strong and secure. I don't like to suture the rectum itself. I instead will either go through the mesorectum or the adjacent connective tissue. So if you notice with my third arm and also the bedside assist, what I have going on is upwards retraction of the rectum while I'm tying this knot. And again, I've had the camera on the below position the whole time and I haven't really run into any issues with exposure or visualization. So to close my peritoneal defect, I'll either use a V-lock suture or a Stratafix. You could also use a Vicryl. And I just run it all the way down and make sure I close this gap. You could have a theoretical risk of herniation of small bowel into this defect if you don't close it, which is always a concern of mine. And that should just about do it. I hope you enjoyed watching this video. I hope it was a little bit educational for you. And certainly I hope it helps you for whenever you decide to do your first SP rectopexy. In one of my next videos, I'll show you how you can do an LAR using the SP, ideally through, again, a fan and steel incision. Thank you all for watching. If you have any questions, comments, or concerns, please, as always, feel free to reach out and I'll do my best to answer them.